Welcome. My name is Dr. Marc Greenwald, and I am the Chief of Colorectal Clinical Services at North Shore Hospital and also the Rectal Cancer Program Director. I want to talk to you about diverticulosis and diverticulitis, two words that a lot of people get confused. Hopefully I can educate you so you have an idea of what these issues are and how they can be problems for you or people that you know. So before we speak about diverticulosis and diverticulitis in particular, it's really important to understand the intestinal tract in its entirety so you understand the role of the colon and then the subsequent problems that you may have. So over here, you can see the entire human body, and then you can see the esophagus coming down. And what happens when you eat, the food goes in this tube called the esophagus, and then down into the organ called the stomach. And the stomach's job is to churn up the food into little pieces and then deliver it to the small intestine, which is in the middle here. That's where the digestion occurs. All the vitamins, minerals, proteins, carbohydrates are all removed in the small intestine. After that, what's left over goes into the colon. The colon starts here on the right side, comes across to the left side, and then down towards the sigmoid colon. We can see it here on this picture just of the colon itself. You can see this area here is called the sigmoid colon. It's called sigmoid for the Greek letter sigma, which is like the letter S. And because this part of the colon typically isn't straight, even though it's drawn straight on these pictures, it is usually pretty loopy. After the sigmoid colon is the rectum, which is the final part of the intestinal tract before the stool exits from the anus, which is the opening. So you can think of the colon really as the trash compactor. After the food is digested, it's delivered to the colon and processed into stool. Diverticulosis are little pockets, little weakenings in the wall of the colon. You can think of them as inside-out pants pockets. You can see that on this picture here. This picture here is a view using a colonoscope, and you can see the little holes that form inside the colon as these pants pockets. In this picture here, on this drawing, you can see these little pockets, again, that form. This diagnosis is typically made on colonoscopy. We see diverticulosis more common in developed countries. The reason for that is because the typical diet and habits of people living in more undeveloped countries don't predispose them towards diverticulosis, meaning people that eat high-fiber diets right from early ages, people that exercise more frequently, tend not to have as much diverticulosis, and that is really something that starts right at the early ages. These little pockets that form, they typically form right next to blood vessels that come into the colon that bring blood to the colon. Those blood vessels make little weakenings in the wall that allow this stretching to occur, this ballooning, this pants pocket to form outside the colon. It turns out that diverticulosis is increasing in the United States. The latest large study, and it's already over 10 years old, demonstrated in 2009 that 33% of people in the ages 50 to 59 have diverticulosis. People that are younger certainly have it, but the incidence is lower. By the time someone gets into their 80s, they have a risk of about 71% that they will have diverticulosis. So this does increase with age. So now we're going to talk about a new term called diverticular disease. And what that means is diverticulosis with symptoms. In the past, it was really diverticulosis and diverticulitis. Those were the two terms that everyone tried to remember and got confused about. itis being inflammation or infection, like tonsillitis or appendicitis. Now, in the medical literature, people talk about diverticular disease. And what that means is someone with diverticulosis, someone who has the pockets and who has symptoms. And there are two broad categories now that we talk about with diverticular disease. The first is what's called symptomatic, uncomplicated diverticular disease. That just may sound complicated. But what it really is people with diverticulosis who have symptoms, who don't have severe inflammation, and don't have severe infection. It's people that just have chronic irritation. It could be left lower quadrant discomfort, some crampiness or bloating. Fevers is typically with diverticulitis, but those are symptoms that occur with diverticular disease. Nausea and vomiting usually occur again with diverticulitis because someone's pretty sick. But diarrhea and constipation can be associated with symptomatic, uncomplicated diverticular disease, or SUD. And approximately 25% of patients with diverticulosis will have some symptoms. SUD, or symptomatic, uncomplicated diverticular disease, is very similar to irritable bowel syndrome. Those symptoms can be quite the same. But typically, with diverticular symptoms, they occur in the left side. Diverticulitis, as I mentioned earlier, which is inflammation, or in worse cases, infection, and can be severe infection, occurs in approximately 1 to 4% of people with diverticulosis. So the vast majority of people with diverticulosis never get diverticulitis. So all these findings of diverticulosis on colonoscopy, as I mentioned earlier, most people don't have problems with that. Another issue that can occur with diverticulosis is bleeding. If you remember, I talked about earlier that the weakenings in the wall occur where the blood vessels come through the wall of the colon to bring blood to the colon. These blood vessels can get irritated and then start bleeding. And the bleeding can be pretty heavy. And about 5% of people with diverticulosis may have an episode of diverticular bleeding. Up here, in this picture, you can see the diverticulosis, and the red stuff is actually blood inside the colon. This is a view from a colonoscopy. And you can see this little arrow that was put here, and then the large amount of blood that's coming down, and that's actually a diverticulum that is bleeding. And in somebody who's bleeding heavily, this can be stopped by placing a little metal clip right on that spot using a colonoscope. Now, it turns out that most bleeding with diverticulosis stops by itself. Occasionally, people need transfusions because the blood loss can be significant, but typically it does stop by itself. Another way of stopping bleeding, if colonoscopy doesn't work, is something called angiography. And that's when a radiologist puts a little tube called a catheter into the blood vessels and then puts some dye into those blood vessels to highlight the blood vessels that are feeding the colon. And you can see that on this picture here. And this is the outline of the colon, and this dark area is the contrast or the dye inside the colon. And if there is a spot that opens up where they can see the bleeding, then the angiographer or the radiologist can then stop the bleeding by placing a little material inside that blood vessel to sort of clog it up. And that can stop bleeding also. Again, these things are not typically needed because bleeding often stops by itself. Even more rare is the fact that surgery is needed for bleeding. That's very rare. That's only when colonoscopy and angiography don't work. So what can we do if we get diverticulosis? Well, you really want to prevent the problems, right? Most people don't get problems. And as I spoke about earlier, there are things that have been associated with diverticulosis and, of course, diverticulitis. So healthy habits really do make a difference in this problem, and this has been studied and proven. So yes, things that are bad are things that typically people like to do: red meat, liquor, smoking. Those things can contribute to diverticulosis and diverticulitis. Also, nonsteroidal anti-inflammatory drugs, NSAIDs, things like ibuprofen and Aleve, Advil. Those drugs, when taken on a regular basis, can increase your risk of diverticulitis. Certainly the good things, they're good for every part of your body. They're good for your heart and they're good for your colon. And that's healthy eating with fruits and vegetables, fibers, and exercise. And it's been shown that a high-fiber diet and low intake of red meat can really make the difference. Certainly smoking, as I mentioned. Obesity is tied to diet and exercise, alcohol intake, sedentary lifestyle. These things can increase your risk. It turns out that if you take a population of people that move from an underdeveloped country and move to a developed country, and you follow that group of people over the years, initially, when they leave their country, their risk in that population of having diverticulosis and diverticulitis is low. But as they assimilate into the new country, over the years, and you follow these generation to generation, you will find that after several generations, their risk of diverticulosis and diverticulitis is the same as the rest of the population. Because as they develop the habits of that new population, then they also develop the problems that are associated with that. And by the way, this is also true for colon cancer. The same things that affect the development of diverticulosis and diverticulitis also affect the development of colon cancer. So let's talk a little bit more detail about diverticulitis. So again, it's inflammation or infection. If there's no signs of infection, no fever, white blood count is normal, X-rays, we talk about imaging, but that's really CAT scan, and I'll show you some pictures in a minute. But though all those things are normal, then it's really just irritable bowel syndrome or SUD, like we spoke about earlier. But diverticulitis can be more than that. And approximately 12% of patients with diverticulitis can have even complicated diverticulitis. So uncomplicated diverticulitis is something where there's just inflammation and infection. You can see that really down here on this picture. You can see the little diverticula, that it's reddened and inflamed. And that's different than complicated diverticulitis, which is when there are one of these things. They're listed there. There's perforation, there's abscess, there's fistula, and obstruction. So perforation is when a hole develops inside the diverticulum and the stool and the bacteria exit, and that can exit into the entire abdominal cavity and cause peritonitis. That becomes a surgical emergency, and we'll discuss that in a little bit. Sometimes there could be a perforation, and then there's containment of that perforation by the body. The body tries to fight these infections itself, and you can get what's called an abscess, and that's right here. You could see this circle of brown fluid. That's an abscess that contains, it may contain some fluid, some pus, some air, but the body has walled that off with other structures, and it's a contained perforation or an abscess. You could see that again in this picture here. A fistula is when there is inflammation or infection that the body tries to contain. A structure right next to the colon will wall off that infection. Very often it is the bladder, because if you remember, I said sigmoid colon is for the Greek letter sigma, which is the letter S. So this colon sort of flops around. The bladder is near it. If it gets inflamed, it may get stuck to the bladder. The inflammation causes this stickiness to occur. That infection may then sort of burrow its way into the bladder and develop what's called a fistula. A fistula is a little tunnel. And there may be fistulas to other organs as well, but really one of the most common is the bladder. And people can have minimal symptoms because this diverticulitis doesn't really get a chance to blossom. It gets controlled by the body, and then all of a sudden, there is this fistula, and people may notice that when they urinate, they pass a little air, or they get recurrent urinary tract infections when they never had them before. And this diagnosis is made, as I discussed earlier, on CAT scan. But those are the symptoms, and you can have it, again, without a clear episode of diverticulitis. Another thing that can happen without a clear episode of diverticulitis, where there's just these minor symptoms going on in the background that we may think is SUD or non-complicated diverticulitis, is stricture or obstruction, narrowing of the colon. You could see that on this picture here. Because what inflammation does is it causes thickening of tissues. And if you get recurrent or ongoing inflammation, those tissues can get thicker and thicker and thicker. And that's really the wall of the colon. It can just keep getting thicker until it narrows the inside so that the stool can't pass through. And that can cause obstruction. And that is one of the listed things that you can see with complicated diverticulitis. So we spoke about CT scan. You can see up here, there's a gentleman inside a CT scanner. For those that are unfamiliar, the CT scan is open. MRIs are generally closed. So for people that are claustrophobic, a CT scan is not an issue. It does use X-rays. Everyone gets concerned about the amount of radiation that they get with CT scan. But the fact of the matter is that although it is some, it is not as much as people get concerned about. The average background radiation that we get is something called 3 millisieverts. That's if we live here. If we live at higher altitudes, you get more radiation. But where we live, it's about 3 millisieverts. A CT scan gives you 10 millisieverts, which is 3 times what you get just living day-to-day life over a year. So there is extra radiation involved, but it's not as much as some people worry about. And a CT scan is really the most accurate way of diagnosing diverticulitis when there is a concern. Because clinical evaluation, the doctor evaluating you, putting their hands on your abdomen, sending off labs, can be wrong 34 to 68% of the time. The other nice thing about a CT scan is that if you don't have diverticulitis, it tells us what else is going on. They really are very accurate tests these days. Colonoscopy is done, but not typically when someone's sick, because there is a fear that it can make the diverticulitis worse. Because with colonoscopy, for anybody that's had one, we do have to put in some air to distend the colon so we can see inside of it. And we also manipulate the colon with the colonoscope. So that manipulation with either the scope itself or with the air can cause greater irritation, inflammation, or even rupture of a contained abscess. So we don't do it when people are sick. You can see in this upper picture here, the picture of the colon and the colonoscope, which is a flexible tube with a light and a TV camera at the end inside the colon. In the middle picture, you could actually see the colonoscope with that light and with the lenses looking inside the colon. It turns out that almost 2% of patients who present with diverticulitis will have an associated colon cancer. And it's not that the diverticulitis causes the cancer. It's that the same factors, as I discussed earlier, diet, lifestyle, that predispose people to diverticulosis also predisposes them to colon cancer. So anybody who has had diverticulitis should get a colonoscopy after they've recovered, typically about 6 to 8 weeks later. And the reason, again, is to make sure that they don't have anything else going on inside their colon. Now, if you've had a recent colonoscopy, you may not need one. But I leave that up to the doctor taking care of you to make sure that you have been properly screened. It also turns out that if someone has had an episode of complicated diverticulitis, and we spoke about the complications earlier, if you've had one of those problems, particularly if you've had an abscess or a larger abscess that has had to be drained by the radiologist, then those patients are at higher risk for having a colon cancer, 6 times that of uncomplicated diverticulitis. So what do you do if you have this problem? Well, we spoke about it a little bit. Fiber can certainly help prevent it, fiber starting as a youngster, but fiber can also help prevent SUD from turning into a more serious episode of diverticulitis, and that has been shown in the literature. Medications, probiotics, unclear. There's mixed data to support their use, and the medications that we have up here on these slides, they're expensive and the data aren't great, so they're typically not used to help prevent further problems with diverticulosis and diverticulitis. Probiotics are easy. The data, again, are not great. They can't hurt, so I never have a problem with someone taking probiotics. The thing that's important on this slide, because many patients ask about it, is should they stay away from seeds and popcorn and nuts? And the answer is no. You do not have to stay away from that. There have been very large population studies looking at populations who eat seeds and nuts and popcorn with diverticulosis and patients who don't eat it. And there is no data when looking at thousands and thousands of people that demonstrate that seeds and nuts and popcorn cause a problem. Now, on an individual basis, I have certainly had patients who have told me, I ate a bag of popcorn, and within a day, I had an attack of diverticulitis. For that particular person, it's a good idea to stay away from popcorn. But as a whole, again, looking at thousands upon thousands of people and comparing those who eat seeds and nuts and popcorn to those who don't, there is no increased risk with those foods. So when someone gets sick, what do? Well, they have diverticulitis and inflammation. One of the things that can happen with inflammation is the colon, again, can get thickened, and people can get either diarrhea because of thickening. It's almost like when you put your hand over the edge of a hose and all of a sudden the water squirts, heavier out of the hose. So that can happen with diverticulitis. If the colon gets a little inflamed and thickened, all of a sudden people can get diarrhea from the inflammation and because of the narrowing as well. Or they can get constipated. So we put people initially on a low-fiber diet while they're sick, while that person is sick, so that the fiber doesn't cause clumping, which can happen inside the colon and cause a blockage. Sometimes we have people drink only clear liquids because the clear liquids sort of don't really make it to the colon. They get absorbed before they even get there. So that way it really allows the colon to rest. And people that are very sick and they're in the hospital, sometimes we really limit their intake completely. But certainly once people are better, then we actually want them back on a high-fiber diet again. In regards to antibiotics, there's a lot of research recently that if someone doesn't have a sign of significant infection, that they can get better without antibiotics. But that person has to be a healthy person. They cannot be immunocompromised, they can't have comorbidities, they can't have signs of significant infection with a fever or an elevated white blood count. And in those circumstances, very often the diverticulitis is really just inflammation and not infection, and that person can get better without antibiotics. I strongly suggest that nobody manage themselves in this regard and that they do seek out medical attention to find out whether antibiotics are the right thing for them if they have these symptoms. So with acute diverticulitis, which is an active episode of diverticulitis, what do? We saw this picture earlier, and I'm going to focus on this right here, which is the abscess, this contained perforation that may have some stool, it may have some pus, it may have some air, but it's contained. It's walled off. It's almost like a little water balloon. And if this abscess, this area of pus, is under 3 to 4 centimeters, which is less than an inch and a half or so, then it very often can get better with antibiotics alone. If it's larger, then we ask our radiology colleagues to drain these abscesses. And you can see here, this is a CAT scan. It's a picture of someone sort of sliced in half as if you had a salami and you sort of cut it down the middle. And the white areas here on the sides, those are the hip bones. The white area in the back here, that is the tailbone. This sort of gray circle here is the rectum. Sitting on top of the rectum here is that water balloon. So you have this circle, you have the dark area there, that's air. You have the gray area with a line, sort of horizon on it, that's pus in there. And we ask our radiology colleagues if they can drain this, because that's not going to get better on its own. So in this next picture here, this person was originally lying on their back, because again, the tailbone is down here. Now they're lying on their stomach and the tailbone is up top. You can see their hip bones again, and this white line is the needle that the radiologist puts in, using the CAT scan machine, into that abscess to drain it. So they put a needle in, and then what they can do is they can stick a little wire through the middle of that needle, and then a little plastic tube called a catheter into that abscess to maintain ongoing drainage. And by our radiology colleagues helping us with that, they can turn an emergency situation into really a more elective situation. And I'll tell you what that means in a minute. But they really can help us and help you by preventing us or allowing us not to do emergency surgery. Because if you remember, when we spoke about it earlier, if somebody has certainly peritonitis, they need emergency surgery. But if they have an abscess that's not getting better, and it cannot be drained another way, then surgery would be the only way. So these radiologists really, really help us take care of you. And you can see in this picture here, that's the drain being put into this person who has this abscess. More about acute diverticulitis. Again, this is peritonitis where there's a perforation and pus and stool are now bathing all the contents of the abdominal cavity. As I mentioned multiple times, this does require emergency surgery because this infection is not controlled and can cause sepsis and even worse situations for the patient. So that's the time when we're operating on people in the middle of the night, on weekends, because they have peritonitis and sepsis. And there are two different things that we can do as colon and rectal surgeons under these circumstances. When a patient is very sick, as they very often are, they have very high fevers, the blood pressure may be low, there may be other issues that are making them very sick, then what's done, and this is the thing that everyone gets afraid of, is a colostomy. And that's only because it's the safest thing to do. We can't remove that piece of colon and put things back together because it will not heal. So you can see that on these pictures here. You can see the colostomy being brought up. This is the colon here. On the other side, we can see the closed end, because what the surgeon does in this circumstance is they remove the piece of colon that has a hole in it, and upstream they give you this colostomy, and downstream they close off the colon. And that's because someone is very sick and we need to take care of the problem and get rid of the infection, and this is the most expeditious way to do that. You can see here the picture of the gentleman with a colostomy bag on him. Now, it turns out he's wearing it outside of his pants, but this could be tucked into your pants, the shirt can be down, and if you could be standing next to somebody who has a colostomy and never know it if it's tucked into their clothing. But that's a nice picture because it really shows you what it's about, and people always want to know what it looks like, and there it is. Another option when someone presents with free perforation and peritonitis is actually to remove that piece of colon and put things back together again. You can see that here. But I mentioned earlier that there is a risk that it may not heal properly. So under that circumstance, we can upstream use the small intestine to give someone what's called an ileostomy. An ileostomy is for the ileum, which is small intestine. We spoke about colostomy, which is for the colon. So what this does, it allows the stool to be brought away from the area that's healing, and it's brought into a bag, an ileostomy bag. You can see this woman who has her ileostomy bag outside on her body, and you can see it here, the ileostomy itself. And what it allows us to do is to what we call divert the stool away from the anastomosis. The anastomosis is the area where the two ends are put together to allow it to heal. Now, this is a bigger operation and more involved than just giving someone a colostomy. So if someone's very sick, we can't do that because it really means more time on the operating room table. The advantage of this, if someone is not that sick and we can do it, is that getting rid of an ileostomy is a much easier and faster second surgery than getting rid of a colostomy. Getting rid of the ileostomy is just a little incision around these two ends, putting them together and dropping them back inside. That is a much, much easier operation than going back on a colostomy where we have the end up at the skin level and then this area here that we have to put back together. And one of the reasons why that operation, that second surgery to get rid of a colostomy is bigger, is because we have to make sure that all of that sigmoid colon, we spoke about the sigmoid colon earlier, that is that loopy part of the colon where the diverticulosis and diverticulitis occurs. We have to make sure that all of that is removed, especially the part that's down by the rectum. Because if we don't do that as surgeons, the risk of recurrent diverticulitis is significant. People can get diverticulosis and diverticulitis in the remaining colon, but it's rare. On the other hand, people very often get diverticulosis and diverticulitis in that sigmoid colon. So when it's time to put everyone back together that has had this problem, we have to make sure that's removed, and we take this open area here where the colostomy is and attach it to the rectum. And then by doing that, we really dramatically reduce that risk of recurrent diverticulitis after surgery, which gets to about under 2%, which is a low number. So these are the two options. Most often, this colostomy is done. That's also called a Hartmann procedure. You see that on the slide. This other option is done less frequently because people need to be in relatively good shape for that to happen. But these are the two things that can be done in an emergency situation. Now, we obviously don't like emergency situations, and it's much better for the patient as well if we can avoid them. So we drain those abscesses when we can. The problem is that if you have an abscess that needs to be drained, and it's more than 3 to 4 centimeters, your risk later on of having ongoing problems with diverticulitis, recurrent episodes, chronic symptoms are very high. And it is a standard recommendation that if someone has had an abscess drained because it was big, that they do get an elective procedure. The nice thing about elective procedures is that we can do them laparoscopically. That means through small incisions. You do not need a colostomy or an ileostomy, so there is no bag. And patients usually go home from the hospital pretty quickly. So the times that we recommend these elective operations, again, is if you've had a larger abscess, if you've had multiple attacks and you keep getting them and you're on antibiotics, it's time to think about it. If you have one of the complications that we've spoken about, a stricture with obstruction, certainly a fistula that's draining into the bladder, which can cause ongoing infections, also it's recommended that an elective procedure is done. And you can see here in this picture what a laparoscope is. It's essentially a thin tube with a TV camera, and then we have these other instruments that we put in to do the surgery. There's usually an incision that's maybe an inch or two that we have to use to get the piece of colon out of you. We have to get that piece of colon that's been the problem. Sometimes the incision's a little bigger if the colon's very thick, but typically people do very, very well with these surgeries if they are needed. Now, I mentioned recurrent episodes, and there is no absolute number. Sometimes people who have had one episode that wasn't complicated, they want surgery. I always tell the story that I had a patient who did business in China, and he spent about 6 months of the year in China. And after an episode of diverticulitis, it landed him in the hospital, but he didn't have an abscess that required drainage, but he was pretty sick for a few days. He said to me, "Doc, I cannot get sick in China. You need to make sure this doesn't happen to me again. I need this piece of colon out of me." And that was a reasonable request. And there are other people that don't travel a lot, that their episodes are not that bad, that have had multiple episodes that really are okay with that. They are at risk for strictures. They need to get their colonoscopies. They are at risk for other complications, and they need to be followed closely by their doctor. And that decision to defer surgery really needs to be made with their physician. But there is no absolute number that says after so many attacks, you need surgery. So I mentioned earlier about laparoscopic surgery and the nice things that we're able to do for people as colorectal surgeons now. And one of the great things about North Shore Hospital is we have a real wonderful, dedicated colorectal team. And by having such a team, we have demonstrated that we are really able to give our patients the best care that they can get anywhere and get them through these operations comfortably and get them back to their regular activities very soon after surgery. We have a dedicated program manager. We have a dedicated nursing unit. We have dedicated operating rooms. We have physical therapists and nutrition teams that see our patients within the first day of surgery. All of this really helps people get back on their feet right away. And then there's something called enhanced recovery, which we have been doing for almost 10 years. And what this is a way of managing people who have colon surgery from the time they come into the office until their last visit. And everything is protocolized, and we really do multiple things to really help get these patients better faster. Using multimodal pain management, which is our fancy terms for using a lot of different ways to manage pain and lower narcotic use, but still have people be very comfortable. Be able to get out of bed that first day after surgery and walk the hallways. People that are able to get their first diet the same day as surgery. All these things really help people recover. Almost 50% of our patients are home by the second day. And that's because they're able to go home. They're eating, they're either passing gas or moving their bowels, they're walking in the hallways, their pain is controlled, and they're able to go home and sleep in their own bed. And it also allows for faster recovery at home, for people to get back to work and their regular activities sooner. And in reality, these people also have fewer problems after surgery. And this has been shown in multiple studies around the world, and we have demonstrated it ourselves here at North Shore. So I want to thank everyone for listening. If anybody out there has any questions or concerns about their problems that are colon and rectal related, I'm happy to see them. We have a good team of colon and rectal surgeons, so as long as your care is at North Shore, I know you're going to be well cared for. And I just want to thank everyone again for joining us today.